Hello, and thank you for joining us for this presentation, Employers' Critical Role in the Fight Against Obesity. This program is part of the SHRM webcast series. You can learn about upcoming and on-demand events from our e-newsletters and the webcast homepage at shrm.org/webcast. SHRM thanks the Diabetes Leadership Council for sponsoring this program and our series of free webcasts for the HR community. All right, let's get this program underway. I'm now pleased to turn over the webcast microphone to George Huntley, CEO of the Diabetes Leadership Council.
Thank you, Connor, and good afternoon to everyone who's joining us. I appreciate your time this afternoon. My name again is George Huntley. I'm the CEO of the Diabetes Leadership Council. I'm also a patient living with type 1 diabetes for over 40 years. In my other day job, I have been the plan administrator of a self-insured health plan for over 25 years. I've been the CFO of a professional services firm based out of Indianapolis, Indiana, who I've just now sold. So I'm now on the other end of that part of my career. But I've spent 25 years as running HR and running a health plan. Really, again, appreciate your time today for this very important discussion. Some quick disclosures. This program is sponsored today by Eli Lilly and Company. Our speakers receive an honorarium, and our medical expert provides occasional insight and expertise to Lilly on occasion. The Diabetes Leadership Council, we are a nonprofit patient advocacy organization comprised of experienced leaders in the diabetes community. We are patients, parents, and allies, educating legislators and advocates, and through this program, employers on policy issues that are important to the health of people living with diabetes and those at risk for diabetes. So we're pleased to present this program. Today's program deals with the chronic disease of obesity and the epidemic of obesity, which is a primary driver of type 2 diabetes. I think that's probably everyone's well aware of that. Today, we are going to talk about it in 3 different segments. We're going to talk about the state of obesity in the United States. We're going to talk about obesity as a complex chronic disease and hear from a medical expert on that topic. And then we're going to end with a discussion with a psychologist on the stigma and bias that goes with obesity and being overweight, and how and the discrimination, how that all impacts our workplace and the workforce that we're all responsible for. So it's going to be a packed agenda. We're going to talk about the employer's role in all of this as we go. If you have questions, as Connor said, please put it into the Q&A area. We will get to as many of them as we can as we go forward. And let's get started. So it's my pleasure to introduce and invite Dr. Allison Sexton Ward to join us. Dr. Ward is a research scientist at the University of Southern California Schaefer Center for Health Policy and Economics. She's an economist with extensive experience on healthcare policy and pharmaceuticals. She's also a co-author on a paper released last year called Benefits of Medicare Coverage for Weight Loss Drugs, which we will undoubtedly talk a bit about today. Welcome, Dr. Ward. Thank you for being here.
Thanks so much for having me.
Great. So we're losing the fight against obesity. You and your colleagues have studied this issue quite closely. Where are we? What's our trajectory?
Yeah, so obesity rates in the U.S. have been rising since about the 1980s, and roughly 40% of the population has obesity. And what we have on the slide here is the average BMI, which, as you can see, the average BMI in the adult population is just crossing that obesity threshold of BMI of 30 or greater. And I think what's important to note is that it's projected to just keep rising. So the status quo trend is not looking great.
So that's pretty depressing. And I mentioned earlier that obesity is a public health crisis, and I know you agree with that assessment. Please share a bit more on the scope of the problem from a public health perspective.
Yeah, exactly. I think a lot of those statistics around how many Americans suffer from obesity are rather widely known, but what is less salient in the conversation is what that means in terms of health. So obesity happens to be the second only to cigarette smoking as a leading cause of preventable death in the U.S. And that between the ages of 40 and 85, nearly 1 in 5 deaths amongst both African Americans and Caucasians is attributable to obesity. So there's a huge mortality impact from all of this. And I think what's really important to understand is that this is with decades of public health intervention. So the current policies and all of these efforts are not slowing the trends that we see. In fact, we continue to outpace projections. So if you grab literature from 10 or 20 years ago, we are far ahead of where they thought we would be at this point in terms of rates of obesity. And a lot of this comes down to not the fact that we don't have treatments, because we have effective treatments now. It's really that we don't have access to those. And that's because insurance plans aren't covering the drugs. In fact, the drugs remain low in terms of coverage, low in terms of uptake rates. And so that's really where we have to start addressing the issue.
And that drives other problems with in the public health arena.
Exactly. So it's really, as economists, we want to think about the entire burden of obesity. And that's not just the mortality piece of it. It's really, that's one component of the burden that obesity causes for society. And yes, there's life years lost associated with having obesity, but a lot of that stems from the increased comorbid conditions that go along with it. So having obesity is associated with higher rates of disability and pain, and then in particular, costly chronic conditions like diabetes, heart disease, hypertension, cancer, stroke, and many more. And that excess comorbidities drives excess costs. So we know the most recent estimates are that obesity is costing the US $260 billion a year in terms of excess medical costs, or that, on average, an American with obesity experiences 50% higher annual medical costs than their non-obese counterparts would. And I think what becomes really hard to measure in all of this, but is a huge part of the burden, is what happens in the workforce, the decreased productivity. One of the huge ways we would want to think about that is how productive you are while you're on the job. And that's hard to measure. But what there are some estimates of is decreased days at work. So I think that there's an average of 3 days per year absenteeism due to obesity.
Yeah, and as an employer, I try to, and the CFO, I try to add up all the costs that any disease costs my company and my people. And you and I were talking ahead of the program today on what the annual medical costs are for obesity. And I think those numbers are evolving because the studies aren't there. They're not, if you look at, I know what it costs for diabetes, and it adds almost $9,000 to a health plan. And the obesity numbers, because the treatments weren't available, the studies weren't available. And I think the information is going to be really coming out over the next period of time, hopefully the next few years.
I think we're just getting into that, right? Where we're learning how if we help patients lose weight, we are delaying and preventing the onset of some of these conditions. And that sort of relationship has not been well researched or teased out. And that will increase our precision in terms of understanding exactly what those costs are associated with obesity, driven largely by the chronic conditions that go along with it.
Yeah, and so our audience today are employers. They're HR and benefits professionals. So what's the picture here for the American workforce?
Yeah, I think it's important to know that obesity rates are highest in that working age population. As you can see there, we have average BMI for 10-year age groups, and it's rising through the working ages. And naturally, as we sort of hit retirement age, the people start to lose weight. And so where we really need to be targeting our treatments is within that working age population, sort of from the age 25 through 65.
Yeah, and you see the drop off in the later years, and that's not because people are suddenly getting fitter in their later years. It's because they're not living as long, right?
Yes, there is mortality parts of all of that. And then there is naturally, I think, as you age, it's some muscle mass that you lose, but you see average weight within the population start to fall. So I think that there's a few different pieces underlying there. But what's true is that on average, a person's weight trajectory grows through until about age 60. You are sort of on the average person has a steady weight gain trajectory and then slowly starts to lose it later in life.
Yeah. So we also know that diabetes hits minority communities harder, but the trend is actually starting in obesity, which makes perfect sense.
Yeah, it's so true. And so here we have graphed the prevalence of obesity in the US population by race and ethnicity. So the Black population is in the red bars there, the Hispanics are in purple, and the white population is in gray. And what you see is that roughly 60% of the Black population has obesity. That's 50% within the Hispanic population and 40% within the white population. That's the second set of bars. And as you look right on the graph, we break it out by BMI obesity categories with the real disparity between race and ethnic groups being in the highest BMI ranges there. In the BMI 40 plus is where we really start to see the rates separate, but also 35 to 39. And those are the ranges that are most associated with these comorbid conditions that have huge both mortality and healthcare cost impacts.
Yeah, exactly. So I think you've sufficiently depressed us with the statistics and the trajectory of where it's going. But I know that you and your colleagues were looking at the benefits of Medicare coverage for weight loss drugs. Share with us some hope that you've found if obesity were actually treated. Why don't you talk us through what this means?
Yeah, so we used our proprietary microsimulation model to look into the future at what would happen under different coverage scenario for weight loss treatment. And so we have in the pink or sort of salmon colored bars and a scenario where just Medicare starts covering it. So really we're missing that working age population. We're hitting people later in life with weight loss treatments. And then in the purple bars, we have commercial insurers joining the fight. And what you can see is if we were to treat obesity, we would see huge reductions in the prevalence of diabetes. So again, these are the reductions in the prevalence. So a vertical bar means we are reducing the prevalence by that amount. So we see huge reductions in diabetes, which I think we all expected, but also significant impacts within hypertension, heart disease, cancer, and disability. And now this is specifically within the Medicare population. I like to look at these diseases in this population because that's where they become the most prevalent. But I think what's worth noting is that in 20 years, if we had both Medicare and private insurers covering these drugs, we could see the prevalence of diabetes fall by 17%, which is in 20 years, that's 40, I think that's about 7 million fewer people with diabetes in what would be essentially 2044, but it's 45 million person years that are reduced between now and then of living with diabetes.
Yeah, I've been in the diabetes advocacy arena for several decades now. I don't dye this gray anymore. And this is the first time I have seen an opportunity to actually bend that curve of the diabetes trajectory downwards. The first time we've seen something that could actually do it. So it is really, really encouraging to see this. And I so appreciate you doing the research to show it in numbers, because numbers matter, and being able to see this and what this could mean if everybody worked together to treat this disease, what it could impact in other ways, and without saying how much better the people actually feel when they are healthier. So all of the above is true. So I thank you so much for sharing this information, Dr. Ward. I so appreciate it. and for setting the stage for the medical panel that's to come. And I'm going to shift us to a poll audio, but thank you again for your time today. So hang on one second, but we're now going to go a quick poll study. Do you know the percentage of your employees with obesity? So those on the call, you're tracking the number of people with diabetes. You're tracking, how much that's costing you, et cetera. But are you actually measuring or know the number of your employees that have obesity? So I urge you, hopefully that's on your screen right now. That will please click yes, no. If you're not sure, many of us aren't sure, and those things, you may not have that access to that information. But curious what's happening here. We've had a couple of questions that have been in the Q&A, one of which is, besides a gym program, what other options can employers offer to fight obesity? We're going to talk about that when we get into the treatments that are there. So hang on, that's coming, but I really appreciate the question. There's some conversation around GLP drugs, and with the use, even with their use, obesity won't decline. I don't think that's correct, but I know Dr. Miller will weigh in on that in a moment. And what is reducing the diabetes prevalence among those in the Medicare population coverage the most? What is reducing the prevalence amongst those?
I'll make sure and address all those, George. I've been watching them. I will tee them up.
Thank you. So I am now going to move us, and I think we've given people time to vote, and let's see where the votes are right now. So only 7% know, 8% know how many people have obesity, and 68% don't even know, and 24% aren't sure. Now, again, as a former CFO, and I'm blissful to be able to say that as former CFO, what gets measured gets managed. And that is true of your blood glucose. That is true of your BMI and your health statistics. It's also true of your health plan. If you aren't measuring it and you're not managing it, and you won't know what the cost is to you. So hopefully this wakes you up, because the good news is if you are in the know, you're not alone. But hopefully this will push you into thinking about what can happen next. So I'm going to actually move us beyond this one because we don't have time. I'm going to move us to Dr. Miller. Thank you so much for being with us. Dr. Miller is an osteopathic board-certified family practitioner. She is certified in obesity management and CEO of the Diabetes and Obesity Care in Bend, Oregon, in beautiful Bend, Oregon, I might say. And I appreciate you joining us today and to share a bit about obesity and this chronic disease that we're now understanding. So please share with us why this designation is so important and some of the drivers that makes it so challenging.
Yeah, to kind of tee up some of the questions and stuff too, we want to set a really good foundation. I see this, there's a lot of stuff in the media right now, and I really want you to urge to go to the scientific data. Don't go to Google, don't go to things like that to determine about side effects and incidents and all that kind of thing. Obesity is a disease. It was recently recognized in early 2000 as a disease. I'm going to give you a good analogy. We've seen this. We're going to try to myth bust a little bit today, George. Individuals saying, yeah, it's just, eat less, work out more. Okay, then if you have high cholesterol, I'm going to tell you to eat less and work out more. If you have hypertension, I'm going to tell you to eat less and work out more. If you have diabetes, you get the gist, right? This is a chronic disease. This often needs to be managed for a lifetime. Yeah, there's certain times in life we don't manage cholesterol. We stop managing obesity-related things. But understand, obesity is getting younger and younger and younger. It's the leading pediatric disease. And it is more than just lifestyle and exercise. I'm not saying that that's imperative. When we looked in 1969, the average weight of a male was 179 pounds. In 1969, did our grandparents and parents, did they go to the gym every day? Were they awesome at the way they ate? No, things have changed, and we're in an obesogenic environment. So there's a lot of opportunities for intervention, George.
And I appreciate that. And we're going to talk for a second. I want to address, there were two questions that came in with regard to how do I even know how many people on my health plan? I'm going to address this while we're pausing really quickly on that. The answer is typically you'll have a third-party administrator or somebody that you are using that's got access to your claims data. There will also be an obesity diagnosis with regard to the claim. If you are not getting an obesity diagnosis with regard to the claim, that's where that core data will be. So that's who you ask to get that information with regard to the employee base on your health plan. You'll be able to see how many claims are coming in with somebody with an obesity diagnosis. So I wanted to weigh that in. So let's talk about this. It's a new designation. And we know that diabetes is a continuum of blood sugars. Obesity is a continuum of body weight. Talk to us about what this all means and how that progresses.
Yeah, we use this concept of BMI, height to weight ratio. It is flawed. I call it excess adiposity. When I have an individual in my office, I say to them, do you think you are your most ideal weight? Yes, height to weight ratio, we classify it as BMI, but understand if you're Venus Williams, your BMI is going to be high, but you have a lot of muscle mass. So when you have a lot of muscle mass, BMI doesn't start to work. But we've got to measure, right? We've got to measure something. And so what you see in front of us are the generalized terms for ideal, normal, overweight. We call it obesity class 1. We don't call it obese class 1. We call it obesity class 1. And we really don't try to call people obese. We call them the condition. We don't call you, George, hypercholesterolemic. And I shouldn't assume that, George. I have no idea if you have a cholesterol problem.
It's fair.
I know, but I shouldn't do that. That's your private information. But we call somebody who suffers from high cholesterol. And I'm going to throw in a really little thing here very quickly. I just saw a comment in there. Well, what about people, if we put them on obesity-related meds, then they have to continue to take it in order to keep their weight down? Yes. I'm going to remind you, if you have high cholesterol and heart disease, you have to continue to take statin medications and blood pressure medications to keep it down and keep your heart attack at bay. That's that bias. You guys, we got to get rid of bias. You're throwing bias in there that it's just lifestyle and modification. And all you're doing them is giving them a weight-related medication to lower their weight. And then you have to continue to do it. We have to do the same for persons with diabetes. We have to do the same for people with COPD and asthma. So we really need to think outside of that box. I am not saying lifestyle isn't fundamental. George, there's a really scary statistic. Adolescents today spend less time outside than prison inmates. I mean, this is ridiculous. We've got to change the way we do things.
That is an awesomely scary statistic. And I hadn't heard that before, so I couldn't even keep a straight face when I heard that. That is absolutely stunning. All right, so we talked about some of the comorbidities. Walk us through what all this means here. What happens?
This is the good news. I know you can look at this as the bad news, but let's flip it around, George. So we're talking about, people have high BMIs, high weight ratios. They are obese. They struggle with those obesity-related things. Yes, but let me tell you this. If we were to prioritize dysfunctional metabolism, that's what we're calling it, dysfunctional metabolism at the core. Look at all the things we can improve. That's saving money. Let's use an example. Let's say we have somebody with sleep apnea and we get them a CPAP machine. We fix their sleep apnea, but do we fix the core defect? No. Let's say somebody has hepatic steatohepatitis. We call that a fatty liver. It's a leading cause for liver transplant and liver cancer. What if we treat that liver cancer? Do we fix the dysmetabolism? No. So if we were to prioritize the dysmetabolism, prioritize the person in the center struggling with this obesogenic environment, the things that pull away from our ability to adhere to our lifestyle, I want some of the listeners to think right now, did everybody get 5 servings of fruits and vegetables yesterday? Did everybody exercise and get enough sleep yesterday? Y'all are going, well, I didn't do that. I didn't do that. So there are things we need to do besides lifestyle to help impact this. And if we were to treat the core defect, look at all the money we would save by its comorbid conditions. Always go to the source, always treat the source, and it will be economically feasible because in treating the person, you're going to treat the comorbidities and you're going to save billions of dollars.
Yeah, and I think everybody on this call who runs a health plan understands the cost of the stuff surrounding that person in the middle. And I couldn't agree with you more. If we solve the problem in the middle, the rest of those things don't happen, and it makes it sense. So let's talk about, what does it take to make a difference?
Absolutely.
What does it take to make a difference?
So this is the first this is a second myth I'm going to bust. In fact, George, this morning I just gave a lecture virtually to the Endo Society for the residents talking about weight-related intervention. And I posed a question to them: what percentage of weight loss is considered meaningful? Now, I can tell you a lot of my colleagues, and I like to, in a very nice way, professionally shame/inspire my colleagues by telling them, many times they tell patients, oh, you got to lose 100 pounds. Like, really? You got to be kidding me. No, a good start is 5%. If a weight intervention, either an exercise plan, a dietary plan, and even a pharmacological intervention achieves a weight loss of 5% or more, it's considered a good start. We see prevention of type 2 diabetes. Now, I saw in the comment, they're looking at prevention of type 2 diabetes, lifestyle versus medication. Lifestyle has about a 48% reduction in progression of diabetes. When you add it to pharmacotherapy, depending on the pharmacotherapy, metformin, pioglitazone, you then reach about a 50 to 60% reduction. And so, yes, when you add on interventional medications to this, now we're talking about obesity, not prediabetes, but do understand obesity is so common in early diabetes and all types of diabetes. And so we want to be mindful of treating it both. That's why the ADA now has obesity-related medications or diabetes meds that have secondary weight loss top of line. Now, 10% is that first target. That means somebody who's 200 pounds needs to lose 20 pounds, not 50. Talk about how discouraging it might be. We're not trying to do a swimsuit competition here. We're trying to impact mortality and morbidity. 10%. The holy grail is 15. 15 is what we're looking for. The rest, you just look good on camera. You just do, you move better in your body and less joint pain. But if we address those types of condition as obesity, whether it's surrounded by diabetes, whether it's surrounded by prediabetes, we're still going to win. And so I want to be aware of that. We have 98 million people with early diabetes. We've got to do something to try and get this trajectory.
Yeah. And again, that hope of only needing to lose 10 or 15%, it is not back to my high school. I don't even have the clothes from my high school days. I'd have to buy new. Who wants to do that?
Exactly.
But this is hopeful that we can get to some place that's going to make a difference in people's lives. But again, right now we know it's vastly undertreated. Talk to us a little bit about why and what's going on there.
There's so many, and I won't spend too much time on this. It really is something that we as clinicians, we don't have those conversations. Just merely having a conversation with persons about excess adiposity, ideal body weight, improving their overall health is just not done. And you know what I hear over and over again? Oh, I don't have time. And that's a whole nother discussion because we're losing our why in medicine. We're allegiant to the paperwork. The paperwork is exceedingly healthy. And so one of the things that we're doing out there is we educate my colleagues that are actual professionals on the front lines of obesity management is to have certain appointments where you don't address everything from the owie foot to the depression. You have diabetes only appointments. You have weight related only appointments. And so you take time to focus on that and you create meaningful goals. Again, it's a chronic disease, right? Just like hypertension. You can't just do it once and you're done. And so I think a lot of this is just changing that framework, but we are getting there.
Yeah, and it's everywhere. It's embedded, and hopefully the audience here of HR folks understand. Even the medical teams need to understand and deal with the bias and the issues with the barriers to getting to the right answer here. And this is totally systemic. So we've got to work together on this. So, all right, we've talked about not getting treatment. Let's walk through the various treatment options, and we're going to start with lifestyle management. We all hear diet and exercise is the key, but it's not really that easy because it doesn't last. Why is it so hard?
Imagine if you told a person who had a above ideal body weight, it's called overweight or a BMI greater than or equal to 25, that we say, okay, you just need to exercise and eat less. That's not recommendations, that's judgments. And so you need to really say, I would like you to move your body more. Don't use the word exercise. People think that's like a forbidden word. You talk about if you're a sedentary person, many people are sitting at their desk right now, you should get up every hour for 5 minutes. Getting up every every hour for 5 minutes decreases mortality by 18%. And so it's more movement. The body likes to be moved. It's built to be moved. I don't care if you aggressively garden. I don't care if you walk. You don't need to become a runner. Gyms are fine, but it is kind of interesting. It doesn't have to occur in the gym. It just has to move that body. I use the plate method. I say, you know what? I want you to take a 9-inch kid's plate, divide it up. The big one's vegetables, the small one's protein, the small one's carbohydrate. Many of us don't do that. That's a way to do it. The Mediterranean diet has the highest amount of data with it, but some people are vegan. Some people, want to eat more protein. And so you have to customize it for the person so they will adhere to it. Because you know what? What happens is that individuals with diet and exercise, they hear it all the time. Y'all, people are doing the same thing. Somebody on the line right now is saying, I lost weight, but then I gained it back. Well, that's because it's hard to maintain diet and exercise, because what do? We're more allegiant to work than we are to ourselves in terms of lifestyle intervention.
Yeah, you're spot on. And again, back for the HR audience here, and you think about one of the questions, what can my health plan do? Look at this slide. One of the things your health plan can do is cover nutritional counseling and cover intensive behavioral therapy. Check with your plan design. You will be shocked you're not covering it. You will give away smoking cessation classes as many times as you people want to take it, because you understand how important it is to stop smoking. Please think of this exactly the same way. Nutritional counseling is a whole lot cheaper than bariatric surgery.
Yep, good point.
And this is really easy for you to do. Please take a note of that. Thank you for listening. But let's go on. We've got these anti-obesity medications that are out on the market. Talk to us about those.
Yeah, I'm going to weave in the comments too, because y'all are propagating things that you're reading on the internet. Okay, first of all, weight-related medications or any medications that have been approved for weight reduction. Now, there's a comment in there, well, what if they don't have diabetes? Remember, there are many drugs that are approved for diabetes that are the exact same molecule that have a wrapping for obesity. So don't get them confused. You don't have to have diabetes to have weight-related medications, but there are a lot of diabetes meds that cause weight reduction. But understand, if you're looking at somebody who doesn't have diabetes, there are corresponding drugs that are the identical mechanism of action, just a different label. Now, there are many. There are some that are inexpensive. There are some that are moderately. There are some that are very expensive, some that people can afford with cash. Yes, you can take them long term. No, you don't have to stop at 12 weeks. Yes, you have to know the type of med, know the type of person, know the amount of weight reduction they need, whether they need 5, 10, or 15%, because not all drugs do that. You also have to know their comorbidities. Do they have hypertension? Do they have diabetes? So it's not just this, here's a diet pill, here you go. We as obesity medicine specialists, we know the drugs, we know the person, we know what they're trying to do. Now, y'all know GLP-1s, which is great, because I can tell that the court of public opinion is weighing in. Everybody's talking obesity drugs, but there are so many misnomers. First of all, I saw this. Well, if you take that obesity drug, you're only going to lose the good calories or the good fat or the good protein, not the bad. You guys, you're so wrong. Any diet that you do, George, even if you went on a calorie restricted diet, you're going to lose a third of your calories, or a third of your body mass is going to be protein loss. A third is going to be fat mass loss. A third is going to be water. I don't care what you do. If you use an obesity related drug, you still have the same proportion. Those obesity drugs, you can look it up with the body densitometry. You do not lose more protein or more muscle than you do fat. That's a misnomer. What is important, though, and I'm going to put a little plug for lifestyle, if you're on a weight reduction related plan, you've got to intake protein and you've got to do strengthening, exercise. You got to do muscle things. You've got to do weightlifting. We so neglect that. We've got to build that. Not only that, they have been studied long term. They have had amazing weight loss data, even approaching bariatric surgery levels with minimal side effects. We say, oh, they got all these side effects. No, these are biologics. George, I make GLP-1, you make GLP-1. We're just leveraging this drug. Now, let's say, oh, well, I heard somebody had a side effect on a GLP-1. They threw up. That's because they ate past that satiety. And when you eat past that satiety, you get GI related issues. Oh, I heard that their gut stopped up. That's because they're not working out. They're not eating those fibers and things. They're sedentary people. So don't always blame the drug. Understand that there are effects of the drug that can turn into side effects, especially if you layer on a different things. But these are so safe and so biologic, and they are going to change the landscape of diabetes and obesity.
And this class of drugs have been around for well over a decade.
10 years. 10 years. Yes.
Yeah.
Yes.
So I think
in fact,
that's another
we've known
thing.
about these drugs for 15 years. We were made aware of these in the diabetes pipeline. They first came from the Gila monster. I actually met and spoke with the very first inventor of Exendin 7. He's a guy out of the VA in New York. Fascinating discovery.
Awesome. Awesome. So hopefully that's been helpful to folks. The only other thing I'll throw out there as we think about that, and this is not going to get into the cost of the medications, but these medications are also rebated. So if you're a health plan, you're looking at list price and you're thinking about the ROI on things, they tend to have about a 50% rebate on that. So talk to your third-party administrator, the folks that are helping you manage your drug plan, and understand what it really is costing your group as you're thinking about things. All right, bariatric surgery is the treatment of last resort, but it's pretty invasive and costly, but it works, right?
It does. In fact, many of our colleagues on the line, their health plans cover bariatric surgery, which is kind of interesting because in order to get bariatric surgery, you have to fail lifestyle and you have to fail pharmacotherapy, which is interesting. We cover the bookends, but we don't cover the middle. And so bariatric surgery is a last resort, and it's so beneficial for those individuals. We are actually cutting part of the body out. And honestly, I'm just going to throw it in there. You know, George, is it really that these people have no willpower that we have to do a surgical procedure? No. It's because this is a chronic disease where hunger and the drive for food is so high, and that a result of their excess adiposity has created so much of these other conditions that we are considering surgery for these patients who have a BMI of 35 or above with comorbidities like hypertension, heart disease, as well as diabetes, or those who just have a BMI of 40 and above with no comorbidities. Because look at the mortality increase or decrease. Look at by operating on them, look at that decrease. So the way I would like to look at it is, why don't we cover and encourage and create a lifestyle plan for individuals that they can do and they can afford with their time? And why don't we give them some of the pharmacotherapy? Imagine how many pharmacotherapy we could cover for the actual cost of bariatric surgery. Why not cover that for those individuals? We call that prevention, is what we call it.
Yeah, and it's an ounce of prevention is worth a pound of cure. And it is from a patient perspective, I'd much rather have the lifestyle and the medications that work than having somebody cut me open and do things there. But again, as you're thinking about your health plans, you're likely covering bariatric surgery, and you're not likely covering, to Dr. Miller's point, anything in between. And I really do urge you to look at that. And this is something that is also, and I think we're now going to shift to a poll question. But as we do, and Dr. Miller, thank you so very much with sharing your expertise in this. I just so appreciate it, and I think the audience got something out of this as well. I'm going to push us to a poll question of is your plan covering anti-obesity drugs, AOM, and anti-obesity medications today? And I think more and more are beginning to, as this is getting into the news. But what's really it's going to drive is employee demand. It's going to be a retention issue. It's going to be an attraction recruitment issue. Would people who are, getting this kind of a response, and are they going to be happy about losing access to it if they've joined an employer that is not covering a treatment that they were covering? As a patient living with diabetes, I'm on insulin. I would never move to another plan that didn't cover insulin. Now, that's an absurd scenario. Every plan covers insulin. I do understand that. But hopefully someday coverage of the chronic disease treatments for obesity will similarly be as mainstream, because we have an opportunity to reshape this country and reshape our workforce. And I'm confident that the math from an ROI perspective is going to work out in our favor. So I'm going to let a few more people click in here. How many of them are doing it? We're just about, I'm going to let it go and see where we are. I do appreciate everybody sharing with us. Okay, so 20% now are on this group are covering it. And it's interesting to see that number rise a bit. 48%, around half are not. And 30%, maybe a third don't know. And that's fine. I would urge you to go check it out. And when you're looking at it, are you covering it? And I should have said this beginning, but are you covering it for obesity versus diabetes? These drugs are the same molecule, the same thing. You've got a type 2 diabetes version and an obesity version. It's the same drug. They just have a different label on it, and it's higher dosages for obesity because the goal there is weight loss. But are you covering it for obesity, or is it only being covered for type 2 diabetes? I would urge you to cover it for both diseases, because both are diseases. So thank you all for sharing this. And it is now my pleasure to invite Dr. Rebecca Pearl to join and talk a session here on stigma, bias, and discrimination. Dr. Rebecca Pearl is an assistant professor in the Department of Clinical and Health Psychology and in Social and Behavioral Sciences at the University of Florida's College of Public Health and Health Professions. That's a mouthful. She directs the Body Image and Stigma Lab, which conducts research on health and appearance-related stigma. And thank you so much for being here today, Dr. Pearl. I appreciate your time. So stigma is a powerful thing. A sizable portion of this country, but hopefully not this audience, believe that obesity is the patient's fault. Let's talk to us about how damaging stigma and bias can be and what it really looks like.
Yes. Well, unfortunately, we know this is a really common form of prejudice in our society. So when we talk about weight bias, I'm sure a lot of people have heard the term fat shaming, body shaming. We're really talking about negative attitudes and beliefs about people on the basis of their weight. And these negative attitudes are often rooted in some really common stereotypes or assumptions about a person's internal qualities, just on the basis of their weight. So making negative assumptions about who someone is as a person, how someone is as a worker, just because of their body size. And together, these negative attitudes and stereotypes also feed into blame for a person's size. And this is, largely rooted in a misconception that weight is entirely within an individual's control. And as you've heard about already, that's a really big misperception, that there's so many complex biological, genetic, environmental factors that determine any given person's weight. So these negative attitudes and stereotypes and blame lead to stigma. And that's when people are, socially rejected, judged, or devalued as a human being simply because of their weight or size.
Yeah, it is powerful, and it manifests in many different ways in our system. Talk to us about where that comes up.
Yeah, so there's a lot of different levels where we can see weight bias and stigma playing out. So if we think about examples of structural stigma or kind of societal level stigma, we can think about laws and policies that perpetuate stigma or that don't prevent against it. So for example, in the US and most places across the world, it is entirely legal to openly discriminate against someone because of their weight, to say that you won't hire someone, to say you're not going to pay them as much. You can do that legally. I do not advise doing that, but it is technically legal. There's no protection against that in most places in the US and in the world. We also see really frequent examples of stigma in media coverage of obesity, including what we've seen a lot in the news coverage of these obesity drugs that have been coming out, but also even in movies, television shows. You see the characters with a higher weight as kind of the butt of the joke or portrayed negatively. And then we can also think of, lots of examples of stigma that happen interpersonally. So between people, we know that weight is the leading reason for teasing and bullying among youth. And discrimination is really common in the workplace, in education settings, and in healthcare settings as well. And then last, I'll also mention what we call the intrapersonal level, or within individuals who have obesity. We see what we call anticipated stigma, or the threat of being stigmatized. So even without a direct interaction that's stigmatizing, just walking into a room and worrying about how others are going to treat them, how others are going to think about them, that really heightens stress and distress, and can be a really unpleasant and problematic experience for folks. And then we also have internalized stigma, or self-directed stigma. Given how pervasive all these stigmatizing messages are in our society, it's really common for people to buy into those negative stereotypes, to apply them to themselves. So to believe that they are lazy or a bad person because of their weight, leading to low self-esteem and lower self-worth.
Yeah, and I think that it just makes it so much harder to get better, if you will, when you are blaming yourself in the process, and it creates this psychological stress, and it's real stress. It has real physical outcomes in this. So talk to us a little bit about how that impacts the overall health of a patient.
Yeah, well, that's a really good point, because sometimes people think that stigma is needed to motivate people to lose weight or to get healthier. And we find time and time again in all the research that is not how stigma works. It has the opposite effect, where it undermines people's ability and engagement in health promoting behaviors, and negatively affects their mental and physical health. So for one thing, any form of discrimination, including weight discrimination, when it affects things like wages and employment opportunities, that also affects things like access to health insurance and healthcare, that affects the kind of neighborhoods they can live in. These are all what we call social determinants of health, or factors that can impact a person's overall health and well-being. There are also direct psychological consequences of experiencing discrimination and other forms of interpersonal stigma. We see this linked to more depression, more anxiety, more eating disorders, as well as lower quality of life and impaired social relationships. And then, as you said, this is stressful, right? If you can imagine, or if you've had an experience of being criticized or being discriminated against or mistreated, those interactions are stressful. And then if you think about this happening day in, day out, even in subtle ways, that adds up over time. And, when people are feeling stressed, they often engage in health behaviors to cope with those stresses that undermine weight management. So a lot of people, when they're stressed, tend to eat more. That's a really common, coping response to stress. And we know that chronic stress is linked to cardiovascular disease and other health consequences that just exacerbate the links between obesity and poor health. And I also want to, say that for a lot of other health conditions, there's been a lot of acknowledgement that stigma is bad. Like if we think about combating stigma for mental illness, for HIV, for cancers, but with obesity, it's often overlooked or not addressed as much, and not recognized as being really harmful.
Yeah, and I think we've got a long way to go on that front. But I think excellent comparison to the mental health areas, the HIV areas, where they used to have it. We need to move, this obesity chronic condition into, this is something that we can treat. It's not the patient's fault. It's not helping to call it the patient's fault. It's not helping at all. So let's talk about how it manifests in the workplace, because this is an HR audience here. So, where are some places that they should be keeping an eye out for?
Yes. So unfortunately, this can seep into all aspects of, hiring, wages, firing decisions. So we know from research that people are biased against employees with a high weight, and that affects hiring decisions. There's what's called a wage penalty for obesity, and it's particularly pronounced for women. So a recent stat here that, a woman with a bachelor's degree makes 12% less than her counterparts who have a lower body weight. And in all these studies, they can control for things like education or parental education, and still there's a discrepancy that points to discrimination on the basis of size, wrongful termination, and just negative perceptions of employees that can affect things like evaluations or those promotion decisions. There a citation at the bottom here of half of managers saying that they prefer to not interact with patients who are overweight. You can imagine another group kind of inserted into that message, like saying that employers don't want to interact with women or with people of different racial or ethnic backgrounds. That would be a shocking statement for anyone to make or to endorse or to hear. But again, it really speaks to the social acceptability of discrimination and bias against people with a high weight, that people are even willing to admit that they don't like employees on the basis of their weight.
Yeah, I was stunned when I saw that particular quote when it came through. And I think, also, again, back to, as employers, as we're thinking about covering the treatments of this and the mental health treatments, in addition to we talk the behavioral therapies and the medications that are now available, it's really important that we think of, it's not the patient's fault. It's not your employee's fault. And that blame barrier is a barrier psychologically to approving the investment in their health. And I urge people to be thinking about that, because you're in a position of making those decisions. So how can you reduce your stigma and bias? If I'm an HR person, where do I start?
Yeah, well, starting is just acknowledging that these biases exist, right? Everybody's human. All humans have biases. So being open to the idea that you might have some of these biases is a really good first step to then doing what you need to do to prevent those biases from influencing decisions or treatment of your workforce. I think it's also important to keep in mind that, employees, not every employee with a high weight, but certainly a lot of folks have experienced stigma in the past, and also have likely made weight loss attempts in the past, right? There's kind of sometimes an assumption that, I can give, someone good advice on how to lose weight that maybe they've never thought of before. But if someone especially has been struggling with their weight their whole life, they've probably tried it all, and they probably, are very well versed in it. And so there's no need to be making comments or giving unsolicited advice to people about their weight. But in terms of, practices for hiring and promotions, trying to institute or implement policies that remove bias as much as possible. So things like not requiring photographs when you're hiring employees, so that you remove any potential for bias that's based on appearance or weight. Having standardized rating systems for evaluations that really try to remove bias as much as possible. And another thing that, has been gaining more and more traction in workplaces are things like diversity training or sensitivity trainings. But weight is often not included in those trainings as an example of diversity. And so maybe thinking about whether there is room in those discussions or in those conversations and in those policies to, among other forms of diversity, recognize size diversity, and make sure that there are policies in place to prevent discrimination on the basis of weight. And then last, just having a no tolerance or zero tolerance policy toward any kind of bullying, any kind of discrimination or disparagement of people on the basis of their weight.
Yeah, and again, that getting this into and treating it as a discriminatory issue, I think we're now, most of the HR world is tuned into discrimination, and adding this to the list, if we can get past that and let that sink in, it's race, color, gender, ethnicity, weight. Add that to that list. It will make you understand the playbook. We just need to make sure we're inserting it into the appropriate page as we're thinking about our handbooks. Okay, so workplace wellness initiatives. These are some things we've had some questions in here about workplace wellness, and is that the only thing I can do? And of course, we know it's not the only thing you can do, but these are popular. There's good ways and bad ways to do them. So let's talk us through some of these.
Yeah, so, even though what they may be well intentioned, there are some versions of these wellness programs that can be quite stigmatizing to people with obesity, especially weight loss competitions or just such an intense focus on weight loss and body size is really not recommended. Because it draws attention to a person's weight in a way that might make them feel very uncomfortable, even if they're not even participating. It kind of creates an environment where maybe people feel more open or bold to comment on other people's weight or to just talk about weight. And even if someone is talking about their own weight, especially if someone of maybe a lower body weight is kind of making self-deprecating remarks about their own weight, or I shouldn't eat that, you can imagine if someone with obesity is with you and there must be thinking, well, what do they think about me? Right? So really just trying to limit commentary about weight overall is a safe bet to preventing any kind of hostile work environment toward people with obesity. And part of that is not having, public weigh-ins or kind of biggest loser style weight loss competitions. And really the workplace wellness programs that are often most beneficial don't necessarily talk about weight at all, but are about healthy behaviors that everybody can benefit from. So healthy eating, physical activity, making sure that they're accessible to everybody and inclusive of everybody without having a focus on weight loss or weight itself.
Yeah, no, very, very, very good points. And we got things here, encourage movement, make the stairs safe and effective. If you're on the 15th floor, that doesn't work so well, but most buildings are not necessarily that tall. Many of us are in a place where that's possible. Employee of the month, their parking spot should be in the back of the parking lot. Maybe the reward is to build a trail for them and maybe a little walking area for your people. But Dr. Pearl, thank you so very much for sharing with us today and spending your time this afternoon. We really appreciate your insight on this topic. And I know the audience got a lot out of this today, and as did I. So again, thank you so much for your time, and look forward to continuing our dialogue together. We are now at the end of our program with 60 seconds to spare, which is a bit of a miracle. We've addressed most of the questions on the way. If you do have more questions, I would urge you to send us a note at employers@diabetesleadership.org. You can get more information on our employer solutions at our website, diabetesleadership.org, and under our resources, we have what we do in employer solutions. We've got a lot of things we talk to employers about on coverage and making drugs affordable, et cetera. I really want to thank you for your time today and for the opportunity to present this information. We hope you found it useful, and wish you success in your businesses and health in your employees.
Thank you. This webcast is sponsored by the Diabetes Leadership Council. The Diabetes Leadership Council is a patient advocacy organization whose members are individuals with decades of diabetes experience and leadership who work to advance patients' first policies related to diabetes at the local, state, and national levels by engaging policymakers and public and private sector influencers. This webcast is part of the DLC's efforts to educate employers on health plan design options that lower their plan risk and costs while improving employee health. For more information, please visit diabetesleadership.org. Before we sign off, we want to thank our presenters, George Huntley with the Diabetes Leadership Council, Dr. Miller with Diabetes Nation, Dr. Rebecca Pearl with the University of Florida College of Public Health and Health Professions, and Dr. Allison Sexton Ward for the information they provided today. And we also want to thank everyone tuning in for being with us and for choosing SHRM for HR webcasts. That concludes this program.